Hello, Ramana sir. Good evening.
Kannan sir, can you just check Facebook Live is on, sir? I would like to one of you to check. Good evening, Ramana sir.
Working live, sir.
Kannan sir, please check Facebook Live is on.
Yeah.
We are live?
Yeah, we are live, sir.
Okay, thank you. So off we go. Warm welcome to the AWRSC community. And I also welcome Dr. Ramana, the founder member. And we have Dr. Ramesh Punjani and the galaxy of core team members, invited faculties, and my dear friends. It's been a pleasant opportunity given by the meeting is technically planned to give a bird's eye view about eTEP. Fundamentals of eTEP is so that people who are just getting into the eTEP will be able to get into the surgery without much of a trouble. Now, I'd like to request our head of the AWRSC, Dr. Ramesh Punjani, to give us a few words and start the meeting, please. Sir, you're in mute mode, please.
So this is an AWRSC initiative. Since the abdominal wall reconstruction consists of a very complex procedures, and these procedures which are of not of very long standing. So they're there for last couple of years, at the most 3-4 years. And therefore, it is very important that we share our thinking process and we standardize the steps. Because if all of us start doing these complex procedures without actually having an in-depth knowledge about it, there is likely to be a problem. So that is the reason we have been working on standardizing the procedure, and this is one such initiative. Now, this is from the South Zone, where Kanakwel has taken a lead, and I'm very happy that we are going to have now a eTEP procedure, which is a relatively a new procedure in the hernia space. And we'll have a galaxy of speakers here, and we'll have our expert, Dr. Ramana, also. So let's go. Yeah.
Thank you, sir. So thank you, Dr. Ramesh Punjani, and with that, we will start the presentation. I will just try and give you a brief idea about why eTEP, and let me share my screen. Am I seen, sir? Okay, good. So let me just try and give my viewpoint or a little bit about fundamentals. I'm sure I'm not a very big exponent of eTEP, but this is how I understand eTEP, and there are experts here to put their views and get me back to the line. And I also welcome the international speakers, Professor Azad and Dr. Richard from US. Thank you for joining us, and the national speakers as well. So starting with hernia surgery was almost happening from 500 or 1500 BC, but later Lichtenstein's was the breakthrough point where hernia surgery started looking at something on prosthetic, where silver and other things were used. But the principle of no tension repair was established in the year 1984, and then there was no looking back for the polypropylene mesh as such. Then when it came to the ventral, and the 80s and 90s had the glory of Reeves operation at various modifications. And then it was in the year 1993, one could appreciate the laparoscopic ventral hernia repair took up, where LeBlanc and Booth published their first series in 1993. And still on an average, about 20 to 30% of the ventral hernia procedures are done in laparoscopic method, whereas last 25 years have seen a lot of improvement and a lot of upcoming procedures coming in. So to start with the fundamental question, why laparoscopy, shorter hospital stay, early resumption of work, and lesser surgical wound complications, these are all very well known facts. And later, when things got into a huger arena, then people started to have a common language of expression of what he or she is trying to do, or what he or she is trying to do from hernia as a procedure as such, and as a classification came in, and it became universally accepted. And then, say from Lichtenstein's to the current modern procedures, There were many stops in between. So it was IPOM, bridged IPOM, later it became IPOM, then became IPOM plus. Then by then, when they came to this level, people understood we should also restore the function. That is where AWR, abdominal wall repair procedures started coming in. And the initial people were talking about anterior component, and later people realized it is more scientific to do the posterior component release. And then it was Professor Reinpold where pre-peritoneal mesh as a concept or as a series of cases was presented. And then I would say in the year 2011-10, these years were the formative years of this eTEP procedure, where Ogdas, Nowitzki, Belyansky, Ramirez, and Rosen took up as an initiative. And from our country, Dr. Ramana Balasubramaniam was the first few to get into the procedure, and they were the ones to standardize the procedure. So what governs the choice? See, fundamentally, defect size, what we are going to talk today is not less than 4 centimeters, somewhere above 4 centimeters and less than 7 or 8 centimeters, where a combination procedure may be required if the defect is much larger, where eTEP cannot handle it. And then how many number of defects? Do we have one defect or multiple defects? And how we are going to stabilize the mesh? And then if and if there is a choice of avoidance of fixation. These are the fundamental core issues where this important publication 2018 came to address, and then from then there was no looking back for eTEP. So abdomen, even though it looks like a cylinder which is given structure by multiple muscles, one could appreciate the core maximum peak pressure at resting or movement is variable, and then the pressures are distributed according to the principles of law of Laplace, where you can see the umbilicus or the center point of the abdomen is there, and then no looking back, and the entire facial planes gets disrupted to start with. So any hernia which is smaller in defect, or when you're picking up at the earlier point, this is one important message: try and deal with the hernia at a much earlier point itself. So once there is a disruption, either in the midline or anywhere of the abdominal wall, the pull-around factors are multiple. It is not geometric force. It works all around. It works on all axes. It works on various pivotal points, where at this point of time, the linea alba is one core structure, one lighthouse which governs or which controls the entire group of muscles, or one which integrates the entire group of muscles. Then came the principle of lateral, longitudinal, and transverse stress. Transverse stress are always lesser, but beware, there is always a transverse stress. But the linear stress is much higher due to various reasons. And this is in some group, it is mentioned as warp and weft. So people really started to begin to understand both things are important. And then, as you very well are aware, the longitudinal stressors are much higher. And the signs of open hernia helped us to understand various levels of various points of mesh placement. Is still retromuscular mesh placement is preferred because of decreased recurrence rates, less surgical site infections, and improved abdominal wall function. The most important driving factor, as I've already told, or the integral part of the abdominal wall strength is the fascia lata, linea alba, where one could appreciate the muscle activity of the abdominal wall, the local stiffness, and the deformation indices. They, as the child is born, as they grow up into an adult, and then from the adulthood, they start getting weakened, and more they are going to become more stiffer by the year. So a closer structure of microstructure of the facial study was done. People really got to understand the linea alba was a fiber reinforced material with relatively stiff collagenous fibers embedded in a homogeneous ground matrix. The principal factors are the strength of the linea, or the elasticity component, a combination of stiffness and elasticity on either sides, the L and T side, and then withstanding ability to acute stressors. So people then realize, as we grew up in the anatomy, we realize we have 9 layers. That means 9 opportunities and 9 different permutations and combinations of procedures came in. where you enter and where you place the mesh and where you repair method, of which these are the areas where people started looking into. At this point, today's point, we are going to catch up on the retromuscular areas alone. See, as things develop, newer techniques in ventral hernia surgery also continuously evolve. So let me group these things into retromuscular methods, suprafacial methods, and intraperitoneal methods. Today's principal discussion is going to revolve around retromuscular methods alone. So of which these are the principal procedures which can be done in this part, but then today we are going to limit up with only to eTEP procedure. So ongoing process of eTEP, component separation can be added to, especially if we need to incise one or more facial planes. You want to generate additional myofascial advancement flaps. And then if you have a difficulty in assisting the facial closure, this is going to be out of discussion today because we are going to limit our discussions to eTEP. So then let us explore what is the technical need of eTEP. The extended view totally extraperitoneal TEP procedure. Yeah, there is a definite limitation in the surgical field in conventional TEP procedure. And then here the eTEP adds to the advantage by allowing entry into the preperitoneal or retrorectus space from any portion of the anterior abdominal wall. Let us see why you should have a wider access in the subsequent slides. More so, it helps to restore the architecture and functionality of abdominal wall to the best possible manner. And then people understood, as I rightly pointed out, they understood the importance of the integrity of the linea. And then the focus of all the procedures shifted to reconstruction of the linea alba, the central tendon of the abdominal wall. So what are the crucial advantages or crucial benefits an eTEP is going to offer us? It is a minimally invasive procedure that's minimizing the wound complications. The mesh can be in the sublay position that avoids fixations. So many principal areas were able to be answered by this one procedure. And then more so, it offered an advantage towards the ongoing access towards one of the release procedures in difficult or impossible closure, where the posterior component was always a stone's throw away for you to do either a limited post component release or a one-sided release or a release, depending on how the sublay position offers superior quality of postoperative connective tissue formation, definitely aiding on to less recurrence and of course less cost, where you do not need any major composite meshes here. So getting into the principal part of the eTEP, first thing is to understand the neurovascular anatomy and keep away from the nerves. Then preservation of the vascular pedicles, especially the epigastric pedicles and the intercostal neurovascular bundles together. And then most important, you also should assess and maintain the integrity of the semilunar facial integrity. And of course, this procedure helps one of the abdominal wall to establish an isokinetic and isometric restoration. Eventually, the principal aim is to restore the linea alba and give an optimal mesh placement. These are the focal components of the eTEP procedure, where my subsequent speakers are going to touch upon. So one important pertinent question, more restoration procedures or release procedures. Here, this is one Carbonell publication very clearly mentioned. This is a very rough formula for you to understand. When the rectus width is 2 times and the defect width is 1 time, on that ratio, anything less than that, sorry, anything less than that, you do only the eTEP or the Reeves Topa. And then anything more than 1, then obviously you have to consider about one of the release methods. So one could see the very famous paper which formed the basis of whatever we are doing today in the ventral hernia, Ogday's paper, where the port placements were all these in this order, where people believed in balloon separation, but now we no more depend on it. And later, multiple publications came, the paper from the IGAR group, then paper from the Surfoscope, where people looked upon various various components of doing a groin hernia repair, the M1 repairs or the M5 repairs. So approach can be from the subcausal, but then let us concentrate on something important. You can be placing a port which is very away from your hernia defect. That is where I would like to interest upon. So people have the dexterity and the flexibility of choosing. Please excuse me. I'm sorry about that. So that's how it works. So the biology remains hernia should be kept as away as possible. So your process can be depending on your dexterity, depending on either you're going to do a lap eTEP or you're going, if it is going to be huge BMI, then you aim depending on your availability of infrastructure, how far away you're going to go. Technically speaking, to have access on one side of rectus and to have comfort of crossover of to the other side of the rectus. These are the two principles. One, the lateral, you come to the medial. You have a hernia in the medial end, you go to the lateral side. That becomes the mantra of it. Then you will be listening to the exponents who are going to speak about me about the technicalities. Let me quickly touch upon something about the outcomes. Having spoken about the fundamental principles, now let us talk about outcomes. Fundamentally, these publications are grouped together. Very limited papers are selectively talking about open eTEP. When you talk about outcome-based papers, they are principally eTEP plus or minus abdominal release procedures or robotic eTEP and plus or minus release procedures. But some or other, if I could see the series of publication which has been happening in the last few years, it sounds a little bit, people are more towards robotic eTEP and robotic TAR for various reasons. So more outcomes are coming up from the robotic. In fact, one of the big systematic reviews also come up already. We'll look a little bit about it. This is one of the publication from a regional hospital, GEM hospital group, where they try to compare eTEP versus IPOM plus. Because the first challenge people are going to question me is, or you want to limit to IPOM or you want to go beyond IPOM, then came the IPOM plus. But here they had a comparative group, fairly reasonable number of cases. They have comparable outcome. The only thing, everybody in every study, the long-term results are going to be awaited. Many papers are talking about couple of years or within 3 years outcome. So we have to definitely wait for a little long time about long-term outcomes. So little bit about the publication from Professor Lu, who's going to speak about these things later, where he very, very categorically stated the operative time is on little on the higher side, but then all other parameters are comparable, or at times you have more comfort and safety, and the incidence of hematomas and seromas are little on the lower side. I'm not sure if somebody is going to jump on me asking about what is the statistical significance of similar. There's the same study which look the longest follow-up is close to a couple of years, and most of the patients were followed somewhere between 5 to 8 months, where the initial baseline symptoms were much relieved, and you had a fairly decent outcome at the end of 1 year. It also has its own share of troubles. People will jump on me, you're talking so much about it. Do you have some data about what are the complications? Hematomas, seromas are as good as any other procedure. Let me not get into that. But then here the most dreaded one is the recurrence due to posterior rectus sheath dehiscence. I would say it has to, we have to come out of the learning blues. And then once you keep the integrity of the vasculature and neurovascular integrity, generally we don't get the end up of it. But of course, the GEM group and few other groups have been honest in admitting they had faced this PRS dehiscence, and PRS dehiscence definitely gives you a not a very comfortable thing, and your options after PRS dehiscence are very much limited. I'm sure the subsequent speakers are going to address to. The debate of either doing a standalone ventral hernia procedure along with bariatric or prior to bariatric, or standalone hernia repairs in obesity patients, especially BMI 35 plus or 40 plus, are always debated. Now, I'm sure this eTEP or the endoscopic AWR definitely has shown some significance and some significant values. And then the principal advantage being the endoscopic repair by and large hugely minimizes the wound related complications, and then the planes are better accessed in endoscopic way. But if you're going to ask me one pertinent question, what happens after the patient loses weight or if the patient has to have subsequent bariatric procedure, then I think we have to wait and watch what happens to these repairs. At this point, we have very clear evidence eTEP is helpful as a standalone procedure. So this is one thing which is very recently published by the Bing and Lee and Richard Wittner group, which also sounds relatively sensible. Let me hear the viewpoints of the other faculty. Also, the pre-peritoneal placement of the mesh. So again, they also claim similar results as good as eTEP. It has all-around access. It has ability to stray away and triangulate, ease of mesh placement. It's almost similar. But the biggest question is how they are going to hold on to the plane, or what are the challenges. This is the only publication I could see on this. Maybe people here may also have started doing this. Let me hear from you also. So coming to the last slide, I've been talking about all about positives. To sum up, what are the limitations? I won't tell these are challenges. Challenges can definitely be overcome. It has prolonged operating time. It has definite steep learning curve. People are very comfortable doing a total proctocolectomy where they have the dexterity of operating from bottoms up or heads down. This becomes a very comfortable thing because you have the habit of rotating the monitors. Definitely it becomes a big, huge boon for operating these patients. And of course, suturing skills and inverse suturing skills are the most important thing. People who are in the younger generation should spend more time in fine-tuning these skills. And of course, people have initially had a lot of difficulty in crossing over to the other side and difficulty in incising the contralateral PRS. These were the difficulties, still it's ongoing. And this is a challenge even for very senior surgeons. At times, they also have to regain the planes if they lose it at the earliest possible time. And the last one, where people are suggesting hybrid procedures, where only there is a skin and which is atrophied bridge of skin which is holding the defect, the huge loss of domain areas. That is where hybrid eTEPs are also being advised. So with these few words I've given, I hope I gave a brief idea about what is that we are going to have a discussion in this evening. Thank you for your attention.
Thank you, Dr. Kanagavel. That was a nice talk, and we've taken trouble to go through all the published evidence. And before we move on to the next speaker, I would like to address just a handful of points. The first is just a matter of being accurate. The pre-peritoneal minimally invasive approaches to ventral hernia started not with Reinpold, who came in much later, but in 2001, Mark Miseres did the, actually he was the original TEP, ventral TEP guy, you know, but he couldn't, he published in 2002, but he couldn't make it very popular, and he kind of gave up on it, I think. So it was a very long gap of more than 10 years before the extraperitoneal space was reclaimed by Jorge Diaz for inguinals, and then Igor Belyansky took it to ventrals. Now, the second point is when you mentioned the qualities of the linea alba, I would say one of the important points to mention when we're talking about quality of linea alba is anisotropy. So the linea alba is not strictly a straight line, it's a band. And if you look at it as a band of a mixture of collagen and elastin, in the longitudinal axis from the xiphoid to the pubis, it stretches more, and in the horizontal axis, it is stiffer, right? So it has its own importance because when you look at the meshes that you place in, the meshes often have the same quality of anisotropy. They stretch in one direction and they are stiffer in the other direction. So it is important to align the stretchable part of the mesh in the craniocaudal axis. So that is better. Otherwise, you can have greater chance of recurrence or maybe stiffness of the mesh. The important thing, I think, in the eTEP is for people to realize, I understand it. Surgeons have this desire to catch on to the latest things. And when it comes to hernia, nobody wants to be left behind. But the eTEP space is a very difficult space to handle and to master. If you think in terms of inguinal hernias, TEP was the most difficult operation to learn compared to lap chole or lap appendectomy, right? So much more than that is the issue of handling the ventral spaces with the eTEP approach. So I would once again, like in yesterday's discussion on TAR, once again ask people, those who want to start or who have just started, is to respect the learning curve. It's very important to spend time learning it and not assuming that one has seen it and therefore one can do it, because there is a genuine potential for harm. Now, you made an interesting point about the lateral approach for medial defects and a medial approach for lateral defects. It kind of sounds very attractive, but like many attractive things, it may be a little bit of an oversimplification. So what I would say is that we all know about the medial defects, right? The standard eTEP approaches are good. No arguments there. Now, what do we do when we have lateral hernias? Do we have a talk on lateral hernias today?
Not really, sir. Not really. We will have a separate session on lateral sometime
Right.
later.
So just a point about the approaches, that when we have a lateral hernia without a medial component, then you have to decide whether the overlap is good enough till the linea alba or the opposite linea semilunaris or not. So if it is, say, a largish defect by the side of the rectus, then you may choose to approach from the contralateral rectus compartment, do a Reeves dissection on the contralateral side, and then go past that linea semilunaris by doing a TAR and have extensive lateral coverage. So what you have done is an ipsilateral TAR and a contralateral Reeves. That is what you have done. And the side is the side of the hernia. So if it's a left-sided hernia, I would do a right-sided Reeves and a left-sided TAR. Okay, this is as far as a defect which is in need of adequate medial coverage. But what if the defect is far away? And when we say far away, how far is far away? Probably a 7 centimeter distance between the linea semilunaris and the edge of the defect is enough to avoid the central compartment altogether. So you don't need to go into the retrorectus plane at all. So there is no need to go do a TAR. All you do is go retromuscular under the transversus. So identify the linea semilunaris and place the ports lateral to the linea semilunaris so that you're completely extraperitoneal to start with and you don't even touch the retrorectus space. So that is when you approach lateral. Lateral eTEP would be a good choice in that kind of situation. It saves you a lot of dissection and a lot of work and a lot of time. Now, final point is eTEP is a newer approach, one of several approaches which are coming up to extraperitonealize the mesh. And because it is a newer approach and because it is such a good approach, there are various other modifications which are coming up, like the stapled eTEP approach. The robotic platform is completely different thing altogether. Um, and the Chinese operation where Bittner was the senior author, it is a bottoms up approach to eTEP. So these are all evolutions. So the procedure is going to continue to evolve and is dynamic. So for me, IPOM is a very solid, established operation with significant downsides, which we have all woken up to now, but it is still a very useful operation to have. But the evolution of IPOM is more or less done. It has been there for now 30 years nearly. So it's not really showing any signs of evolving. So all the evolution is going to come in this extraperitoneal space. So eTEP is a procedure worth watching because of that. So that's it for me. Thank you for this and sorry for such a very long comment.
Thank you, sir. Thank you. Oh, Dr. Kannan, please.
Yeah. Thank you, sir. Thank you for the brief overall idea about the eTEP and as well as the fundamentals. Before going to the next talk, the perspectives of eTEP anatomy, I will brief just something about Richard Liu. Richard Liu is the Associate Program Director in Division of Minimally Invasive and as well as Foregut Surgery in the Department of Surgery at the University of Texas Medical Branch, Galveston, Texas. He completed his internship and residency in general surgery at the University of Texas Medical Branch at Galveston. During his residency, he demonstrated a keen interest in minimally invasive surgery as well as teaching. So for that, he has been honored with various awards, including the L-Star Resident Surgical Olympic PGY 5 champion and the Golden Apple Award in Stimulation, and as well as Gold Foundation Humanism and Excellence in Teaching, and the Thayer Award for Excellence in Teaching. He was also elected as a Relic Ross Scholar and as well and a nominee for the institution's best resident. So that is very important to note here. And following residency, Dr. Liu completed a fellowship in advanced GA and minimally invasive surgery at the Annie Arundel Medical Center in Annapolis, Maryland. During his time there, he trained with world-renowned experts in abdominal reconstruction and hernia repair as well as foregut surgery. Dr. Liu is diplomat of American Board of Surgery and a member of the American College of Surgeons, Society of American Gastrointestinal and Endoscopic Surgeons, Texas Surgical Society, and the International Hernia Collaboration. So Dr. Liu's clinical interests, especially including the minimally invasive abdominal wall reconstruction, ventral hernia repair, inguinal hernia repair, mesh complications, and of course, benign biliary surgery also. And apart from the surgical work, he is very much fond of spending time with his family. Especially, it is very difficult to, especially the surgeons who are finding difficult to spend time with the family, but he is very keen interest spending time with the family. And he is a very good racquetball player, and he is interested in cooking, photography. Of course, he is working on cars also. So, his perspective, it is not an easy thing. These are all three-dimensional objects, has to be explained in two-dimensional view. So let us see the E's perspective of anatomy. Dr. Richard Liu, over to you.
All right. Hope everyone can hear me okay. Thank you so much for that kind introduction. So let me get started here and share my screen. All right. So as mentioned, I'm from Texas. It's really early right now, and hopefully I'm awake. And what I'm trying to do today is give an overview on eTEP anatomy. And thank you, everyone, for giving me the opportunity to present this today. Okay. I have no disclosures. So as an introduction, definitely was a great overview on the last talk on what eTEP is. And if I could sum it up in just one line is, it's an approach to abdominal wall reconstruction, allowing direct access to the retromuscular space with an intact posterior layer. And I think it's key to note that eTEP is an approach. And very often, if you're dealing with a larger defect, you will have to get into the intraperitoneal space, or sometimes even go into the subcutaneous space for closure. And again, it's simply an approach to access the space, and it's versatile because you can access it pretty much anywhere on the abdomen. So this is a cartoon from Dr. Nowitzki's book. And here it just depicts the abdominal wall muscles in cross section. And with retromuscular repair, as mentioned before, it's all about trying to choose which retromuscular planes you want to get in. For example, if you want to do a reef stopa, you want to dissect the retrorectus space. If you want to get out laterally for a lateral hernia, you've got to get into the pretransversalis space behind the flank muscles. Well, what about a subcostal hernia? What about a subxiphoid hernia? In those cases, you might need to expand the plane of dissection above the costal margins and into the pre-diaphragmatic space. And those are all sort of things I'll briefly touch on later, but obviously are probably talks for another day. And obviously this is the typical average male in the United States. I'm totally being sarcastic here. But with eTEP, I like to think about joining three spaces together, and the bridge to join these spaces is the midline, which is the preperitoneal space. So let's talk about this. So, the first space is it sounds like someone's not muted. If you could mute your microphones, that'd be great. So the first space is the ipsilateral retromuscular space, whatever side you want to get in on. And then the second space is the bridge to the other side, the preperitoneal space. And in the upper abdomen, that is given by the falciform ligament, the adipose tissue from the falciform ligament. And down below, it's from the umbilical ligaments. As I'm sure all of us are aware, whenever we're in the intraperitoneal cavity, when you look up at the abdominal wall, you can typically see this fat blanket. Now, a relative contraindication to eTEP is if you have a large midline incision from the xiphoid to pubis where this preperitoneal space is disrupted. It makes eTEP a little bit more challenging, as you got to make sure that you're staying right on the linea alba and taking all the tissue down without causing injury to abdominal viscera. Now, once you get past this preperitoneal space, you can now enter the contralateral side, which in this case, I've depicted as the right side. And now you have joined the left, the middle, the right, and all becomes one plane. There's many different ways to access the retromuscular space. I like to do a direct trocar entry and dissect this bluntly with an endoscope. And as you can see here, I'm on the patient's left retrorectus space and we're looking downwards. For these slides, I've made a little legend on the bottom left corner. So the arrow is pointing in the direction of where I'm looking. And as you can see, the pubis is down below. You can see the white layer, which is the posterior rectus sheath. And out laterally, it's hard to tell where the actual border of linea senonaris is, but we know we're there because we see a neurovascular bundle. And those neurovascular bundles mark, obviously, linea senonaris, and we try to leave those intact as much as possible. Now, up above, I teach residents with these retromuscular dissections that fat hides the good stuff. In this case, you can see the epigastric vessels up above, and there is a little bit of fat here. Now, this is important because when you're dissecting this space, you should always try to hug the posterior rectus sheath and brush everything up. And any fat that you see could either be enshrouding a neurovascular bundle, epigastric vessels. It could also be enshrouding a branch from the epigastrics as well. What's a little bit more subtle here is that I've marked where this arcuate line is. And again, this is not a dynamic picture, but if you're in this space, you can typically see a little ridge, a ledge where there's a drop off. And you'll see that above that ridge, you have a pretty robust posterior rectus sheath, and then it becomes very thin. And that's the transition towards simply having, excuse me, transversalis fascia. So you can't talk about eTEP without talking about the crossover maneuver. And this is really what makes eTEP eTEP, being able to join these spaces together without entering the peritoneal cavity. So here, what I'm doing is I'm making a small incision on the medial aspect of the patient's left posterior rectus sheath. Again, we're looking towards patient's right side. And I'm trying to expose the adipose tissue from the preperitoneal space behind it. Now, what's important here is to note that my incision is not directly at the interface between the muscle and the linea alba, but a little bit below it. I think a lot of times people can be scared of going too high, or sorry, going too low and making an inadvertent hole in the peritoneum. Obviously, that is painful because this space will collapse very quickly. However, if you keep trying to always stay right at the junction between the muscle and linea alba, I think it puts the linea alba at risk for inadvertent injury. Also, once you start doing bigger defects, if you don't leave a nice cuff on the posterior rectus sheath, what can happen is at the end, those anterior fascial edges can retract backwards and lateralize, and it makes closure from a posterior aspect a lot more difficult. So I try to leave a little bit of a cuff of posterior rectus sheath on the linea alba. So as you continue this dissection, what you should see beyond the posterior rectus sheath is adipose tissue. Now, if you're in the upper abdomen, as we are here, that adipose tissue will be from the falciform ligament. If you're in the lower abdomen, below the umbilicus, well, that's going to be from the umbilical ligaments. And then the next step here is to clean off linea alba. So all of the fat needs to be brought down off the linea alba to really expose the true muscle fibers, or the linea alba fibers. And here you can kind of see the crisscross decussating fibers here. One thing is important though, is when you get into this preperitoneal space and you start to dissect it and you don't see linea alba, you have to take a couple of minutes and make sure that your orientation is correct. Because what I've seen, unfortunately, is that if the incision is made too high, you have actually gone through the linea alba and the fat that you're seeing is subcutaneous space. And if you keep dissecting there, what you'll see is eventually the OR lights. So, you know, you always got to make sure that you find linea alba and preserve it at all costs. As you continue this dissection away from the camera, you'll start to see on this left-sided picture here, you'll start to see this pink shadow. And what that shadow is hinting at is that that's the contralateral rectus muscle. Now, using monopolar Caubery, sometimes you can buzz this posterior layer and see if the muscle twitches or jumps on you. But usually I just make a small window and take a look. If you see muscle beyond that incision, well, you're in the right space. If you don't, you got to ask yourself, well, is that atrophied muscle from some other incision? Or are you seeing subcutaneous fat? And if it is subcutaneous fat, what you have to do is make that incision on the contralateral posterior rectus sheath a little bit more lateral so that you actually get into the contralateral retrorectus space. Now, once you're in the right spot, if you continue this incision and follow the direction of the rectus abdominis muscles, you should end up getting a view like this, where you can see both rectus abdominis muscle groups, and in the center, the linea alba, and again, down below the preperitoneal fat, and in the upper abdomen from the falciform ligament. And again, it's very important to try to clean the linea alba off and get all this fat down, as it will just hinder you when you close anterior fascia. Now, usually I like to cross over in the upper abdomen as much as possible because I can find those planes a little bit easier than below the umbilicus. And here's why. Once you're past the arcuate line, things can get a little bit tricky because you'll have thin transversalis fascia, and transversalis fascia actually has two leaflets. And sometimes it can be difficult to get into the right plane. So in this image here, what I have done is I have dissected free the ipsilateral or the left rectus, retrorectus space. I've defined the linea alba here in the middle. And as you can see, this patient had kind of a widened linea alba up top. And most people in the infraumbilical region, this tends to taper down and become more narrow. But as you see here, this is the arcuate line. So where I'm pointing to with my scissors here, this is a good posterior rectus sheath, but you can see this clear transition towards transversalis fascia. Now, if I incise this here, what I will get is the contralateral rectus muscle. And this is exactly what I do. And so this is how we complete the crossover in the lower abdomen. And you can see the contralateral rectus muscle here. Now, again, before choosing to do an eTEP procedure, you kind of have to have a game plan on what retromuscular spaces you want to join. So in this next slide, what I have done is I've done for this patient a reef stopa or retrorectus repair. And the extent of my dissection will be at the contralateral linea semilunaris as marked by these neurovascular bundles. Okay, and you can see this is the posterior rectus sheath. And right here, this is the incision of the posterior rectus sheath that I had to make to perform the crossover and access that contralateral retrorectus space. And down below, you can see the falciform ligament. I think that the upper and lower extent of the dissection can be quite tricky. Again, as mentioned already, the TEP for a inguinal hernia is difficult already. But I think when you start up high and move down low, if you don't keep your orientation, I think you can get into trouble pretty quickly. So it's my belief that you should always look at landmarks around your operative field to try to guide you. So in this case, to develop the space of Retzius and get into this preperitoneal space here, I think one key thing is to follow the directions of the rectus abdominis muscle. Because if you don't go straight north to south, what can happen is you can veer off on one side or another, and very quickly will you be knocking on the iliac's door, which could potentially be less than ideal. And so it's always important to follow the landmarks here. So as you can see, here is the right rectus, the left rectus. It can be very difficult if the patient has a very fatty suprapubic area. Also to note are branches of the epigastrix. So if you see a vessel that's heading towards midline, that's likely not the true inferior epigastric or the main branches of the main branch or main inferior epigastric artery, but simply a branch. And don't follow this as the north and south on your compass, but rather the rectus abdominis muscle. So the next few slides, I know that a transversus abdominis release is likely a good topic for another talk, but I just want to show sort of key anatomy on how you unlock these spaces. Okay, so in this case, I'm looking towards the patient's right anterior superior iliac spine, and you can see the epigastric vessels in the top left corner, and in this view, you can see the arcuate line. So a clear transition between the posterior rectus sheath here and a drop off to where it's simply transversalis fascia. And again, this preperitoneal space below the arcuate line and lateral to the epigastric vessels is the space of Bogros. And this is where you would initiate a bottoms up TAR. So again, joining the retrorectus space with the pretransversalis space to widen or broaden the retromuscular space for adequate mesh coverage or a medialization of fascial edges. So once you exploit the plane and get into the space of Bogros, you can divide the arcuate line, dropping the transversalis fascia and peritoneum downwards. And now we have entered into the TAR plane, as you can see here. You can see the transversus abdominis muscle fibers bare right here, okay? Now, in green, I've marked the linea semilunaris, and you can see it pretty clearly here. But what's also key to note is that you can also see the neurovascular bundles. And it's always important that you do your best to preserve all of these guys. And if you're going to expand into a TAR, always make sure that you're making the incision to access the TAR plane medial to the neurovascular bundles. Now, what about up top? So if you start doing eTEP, I recommend that you start with smaller reef stopas, primary epigastric, primary umbilical hernia that has wide diastasis. And with these, there should be pretty clear tissue planes in the upper abdomen. And as you continue your dissection in the cranial direction, you'll notice that the posterior rectus sheaths will have kind of tented up. And those are where the posterior rectus sheath will insert on the costal margin, right? So, this is where you can also access the TAR plane and do a top-down TAR. But not only that, you can also dissect below the xiphoid and get to the subdiaphragmatic space. So this is useful for things like a subcostal hernia from an open cholecystectomy or whatnot, for a subxiphoid hernia following a heart procedure where the sternotomy might have gone a little bit low. But what's interesting to see here is that you can see both posterior rectus sheaths inserting into the costal margins. And you can kind of make out two separate layers of fat. I'll go to the previous slide. So if you can kind of use your imagination here, you can see that there's some fat associated with the xiphoid, and there is the preperitoneal fat, which is the adipose contributions from the falciform ligament. And between the two, there's actually this plane of dissection. All right. So you can actually, again, go under the xiphoid in this plane. A reason why I've circled this here is because on the next slide, I'm going to really zoom in on the anatomy. So this particular patient had a subxiphoid hernia, and what I'm trying to do is get into the subdiaphragmatic space. So again, this is looking at this ridge on the left posterior rectus sheath. As you can see here, you can see three distinct muscle groups. So up above is the left rectus, below is the transversus abdominis muscle, which we do have to cut to access this space, again, taking down that ridge. And below it, you can see the diaphragm muscle. All right, so this line that I'm pushing down on my scissors, it's actually the contributions of the diaphragm muscle to the posterior rectus sheath. So in the upper abdomen, the posterior rectus sheath actually has contributions from the diaphragm. So, three separate muscle groups that you have to worry about here. And this can be very tricky because, again, all these dissections are retromuscular repairs. So muscle needs to go up at all times. If you see muscle on the floor while you're dissecting, you've got to very quickly realize this and get into the correct plane. If you begin to start taking down these diaphragm muscle fibers, what you have done is caused the iatrogenic Morgagni diaphragmatic hernia. So if you carry this far enough, you can really get your mesh far above the costal margin. So as you can see here, we're looking up towards the patient's head. You can see the right rectus and the left rectus, right rectus here. These are mislabeled, and the left rectus. And you can see that the diaphragm is over here past the costal margin, and this white structure here is the central tendon of the diaphragm. So you can really get wide lap of mesh. So some take-home points. So before you approach a case with eTEP, you have to kind of decide the amount of retromuscular space and which retromuscular spaces do you need to develop, whether you need a reeve stopa, a retrorectus repair, a transversus abdominis release, or if you want to release high past the xiphoid. It's always good to leave a cuff of tissue on the linea or lineas. So again, try to preserve and give yourself a little bit more of like a working room and a margin of safety for the linea alba and linea seminaris. Remember, fat hides the good stuff. So as you're developing the retromuscular space, particularly retrorectus, that fat in that space needs to go up as it can hide the neurovascular bundles, the epigastric vessels, and branches. And if you start digging into it too much, you might cause bleeding in a space that is hard to maneuver in. Always be cognizant of the muscle fiber direction. So the rectus abdominis muscles, those fibers should be going craniocaudal, transversus abdominis release, those fibers should be going left to right. But always pay attention to those because they can kind of hint at whether or not you're staying in the right plane and heading in the right direction. And as always, with any retromuscular repair, whether you're doing it open whether you're doing a transabdominal approach or if you're approaching this with eTEP, always remember muscle up at all times. And I think that's all I have. So thank you so much for your time. And please let me know if y'all have any questions.
Thank you, sir. Thank you very much, Richard Lou. It's an excellent, extraordinary talk. In fact, you have given overall view over the perspectives of eTEP anatomy. It's in fact the star of the talk. You have given all the details about the space creations, pre-peritoneal spaces, space of ridges, bogras. Of course, the creation of subdivided space is very, very difficult. In fact, in your pictures, very clear. Everyone easily can understand. And tell us the technique, how you can avoid neurovascular bundle injury during the dissection. That is the key, because most of the patients coming with the pain after the surgery, weeks, even months time. So all your dissections are very clear. It's very nice. In fact, everyone, you have taught me and taught us everyone about the anatomy of the anti-abdominal wall. Tell us the technique to avoid the injury of neurovascular bundle.
Yeah, so I think the idea of the neurovascular bundles is that you have to find them before they find you. And so when you are dissecting in the retromuscular space, again, all of that fat, all of that areolar tissue needs to be lifted off the posterior rectus sheath. And also another thing too, I've seen with patients that have a very wide retrorectus space, you might see a little perforating branch from the rectus abdominis muscle down towards the floor. And the question is, well, is that a neurovascular bundle or not? If you use monopolar cautery and kind of buzz and apply some cautery above or below that vessel, and if the muscle twitches, that's probably a neurovascular bundle and you need to spare it. So another thing too, as you're applying cautery, buzzing and pushing all of that tissue away from the posterior rectus sheath, if you see the muscle start to twitch and move above you, that's a good indicator, a good clue that you're getting very close to a neurovascular bundle and you should beware.
Thank you, sir. And one more thing regarding the retroxiphoid space creation. So what is your technique? Because most of them finding difficult to create the space. Space of progress is okay. Subxiphoid is very difficult. Tell us your technique.
Yes, I think it's being aware of, let's see, I'm actually gonna share my screen one more time. So
yes.
See here. Let's go back to that slide here. So I think it's very important to, first of all, in this plane, also make sure that you have encountered 3 muscle groups, because if you don't see the TA muscle up this high or the diaphragm muscle, I think you might be in the wrong plane. So just remember muscle up at all times, and that if you're trying to get into the subxiphoid, subdiaphragmatic space, well, that muscle should be pushed up. Initially, trying to dissect this area can be tricky. It's all about finding this plane between the two different fat layers. So one is the subxiphoid fat pad and one is the preperitoneal fat from the falciform ligament. And really what you must do is apply adequate traction on one or the other. So in this view here, to get into this space, I would do one of 2 things. I would either pick up on this xiphoid fat pad with one of my hands and then brush this bottom part away, or pull on the preperitoneal fat towards my camera and then brush the xiphoid up. And that can help exploit this plane. I forgot to mention also, when you're trying to dissect under the xiphoid, there's always these 2 pesky branches, vessels that will bleed on you. And so try to find those before they find you as well.
Thank you, sir. Thank you very much. It's a really overview about, and as well as eye-opening for everyone. I like to get the opinion from our stalwarts like Dr. Ramana sir. Ramana sir, your comment on that, please.
One thing I would like to emphasize is that many of us have been talking about eTEP from 2015, and I have been teaching, lecturing, and hearing and watching people lecture from the level of Igor and Jorge Diaz right down to our local friends and colleagues. And it is very difficult to make this talk of anatomy interesting because everybody has heard eTEP anatomy talks today, and it's beaten to death, honestly. So this talk as such would be the lowest priority for a surgeon to hear or watch. And it is extraordinarily difficult to make this talk anything beyond, uh, just above average. And what Richard has done is truly remarkable. And I think this is probably the finest eTEP anatomy talk I have heard in the last 5 years. And I must say that, Richard, you're a star and you will get many invites because of this talk today.
Thank you. Thank you so much for the kind words, sir. I really
And
appreciate it.
I hope you're part of the AWR community on Facebook. If you're not, you should go there because I'm sure people are going to be complimenting you.
Definitely, I'll look into it. Thank you so much.
Sure.
Thank you, sir. Thank you very much, sir. Pramod, sir, your comment?
Actually, I loved the pictures, the intraoperative pictures that Dr. Richard showed. I just messaged that on the chat. And those pictures, I was really wondering how could he get such fantastic, clean pictures, the kind of imaging system and the pictures that he has got. Not only has he taken the pictures, I think probably he knew that this picture is going to be useful for his talk. So he planned in by taking those pictures with a view to teach someone. So we all do surgeries and we forget about, we just record them and we don't think that what will be useful when we look at these views. And that's also a great quality. So I thought that Dr. Richard is a born teacher. So even while operating and looking at those views, he's thinking about what if I click that picture, it will be very useful to teach someone. So that I loved actually.
Thank you, sir. I think Rahul Mahas wants to speak something. Rahul, sir?
Yeah, it was a fantastic presentation, Richard. And your images are really fabulous images. And I've seen your videos on Facebook and International Hernia Collaboration Facebook group. And you do a fantastic work. And your TAP procedures for inguinals and even the other TAR procedures also, they are very nice. Thank you. Thank you for your nice talk.
Thank you all so much.
Thank you. Thank you very much, sir. Any other comments from the participants or faculties?
I would just like to add that this has taught many of us to start looking at when we are operating, if we find a very great view, to think about taking that picture and preserving it for including in our talks or for teaching. That's what I learned today.
Good morning.
That's also a great thing about having residents around because, I can look over and see that they're a little bit lost and puzzled. And, whenever I slow down to talk to them, that's when I tend to snap these pictures. That one picture with all the neurovascular bundles, I actually cleaned it up for the anesthesiologist to see, so they could see, what they're usually numbing up for their TAP blocks. Yeah, it's always nice to have these pictures for documentation for sure. But thank you so much for the kind words.
Yeah, good morning, Mr. Richard. I want to ask you one this thing. For all surgeons, can you just point out what are the safety limits we should follow to maintain the extraperitoneal, even infraumbilical or supraumbilical? Just a brief of your experience, please.
Yeah, so I think physical exam is definitely key. And if you have a complex hernia with multiple incisions, I think it's very prudent to get preoperative imaging. And I think that on the scans, if I'm approaching something eTEP, I will always look for an intact segment of linea alba, and particularly that preperitoneal space, so the falciform ligament or the umbilical ligaments. Look at the CT scan and see if there's actually a margin where I can drop all that under linea alba. And, some patients who have had a giant X-lap, those I wouldn't recommend eTEP, and I would do a transabdominal procedure, get all the adhesions down, then climb into the retromuscular space. But for eTEP, it's all about finding a nice bridge, that golden bridge to cross over to the other side.
Thank you. Thank you for it. Thank you.
Naveen?
Any other questions?
So due to the paucity of time, we'll just move on.
Thank you so much.
Gives me,
Thank you, sir.
thank you, Richard. Have a nice day. Hope you can get some sleep before going to work. Right. Okay. So the next talk is by dear good friend, Dr. Rahul from Bombay. I've had the pleasure of knowing Sir all the way back from 2008 when we went to Strasbourg together, Dr. Deepak, Dr. Rahul and me. So today's talk, what Dr. Rahul is going to be talking on is basically when are we going to be choosing our patients for a proper eTEP procedure. Hopefully, Sir's talk is also going to be the contraindications for a proper eTEP procedure. Okay. And I would like, Sir, even if he's not getting it covered during the talk, whether he can tell us a little about the learning curve of the procedure. Thank you, sir. Rahul, you can go ahead.
Yeah. I'll share the screen first. Can you see my screen now? Can
Yes,
you see
it's
my
visible.
screen now? Yeah.
It's visible, sir. You can go ahead.
Slides not on, sir. Slides not.
Yeah.
Yes, sir.
One. So, thanks for my introduction. And Reeves Topa has introduced the retromuscular dissection for the ventral hernia repair, and they have dissected the retrorectus space, and they have placed a mesh in the retrorectus space, and this has made almost a gold standard. So Professor Reeves Topa has published the retrorectus space and for the placement of the mesh in open ventral hernia repair, and that technique has become the gold standard as of now. Now, evaluation of laparoscopic hernia surgery, as Dr. Kanagvel has already mentioned about these points, but still I want to mention few points here. It started in 1993 when LeBlanc has introduced this IPOM procedure, which was a bridging. It has its own complications and recurrence. And to avoid that, in 2000, M. Franklin has introduced IPOM Plus, which is with the closure of the defect. And then in 2002, Hope OE has introduced this TAP technique with the pre-peritoneal mesh placement for the ventral hernia repair. And then in the same year, Rediford has introduced this transhiatal retromuscular placement of the mesh, that is the MELOS. And then for the 10 years, there was nothing which has happened in the laparoscopic ventral hernia surgery. And in 2012, Jose Diaz has introduced a novel technique of an extended view for the inguinal hernia repair. And in the same year, Yuri Nowinski has published his first study on the transverse abdominis release. This was the innovation for the ventral hernia, large ventral hernia repairs. And the combination of these two, when it's considered by the Igor Balansky, and he has introduced this technique for eTEP Reeves Topa or eTEP TAR for this ventral hernia repair. Now, the advantage of Reeves Topa procedure and advantage of minimal access surgery has come into consideration for the enhanced view total extraperitoneal repair, that is the eTEP repair. So I am Dr. Rahul Mahadar today in front of you for presenting eTEP indications and extended indications. Now, Jorge Diaz, he has introduced from Colombia, he has introduced the eTEP technique for inguinal hernia, and Igor Balansky has extended this eTEP technique for the ventral hernia. Now, what Jorge Diaz did is the standard laparoscopic inguinal hernia ports were in the midline. He has shifted this port to the lateral abdominal wall and anterior abdominal wall. And Igor Balansky has taken these ports way above into anterior abdominal wall to deal with the ventral hernias. But while dealing with the ventral hernia, what is important is shift the midline or cross the midline from one rectus muscle to the other rectus muscle. And that is the most important thing, what he has described for the ventral hernia repairs with the eTEP technique. So eTEP procedure involves opening the retrorectus space along with the preparatory space of radius and Bogros at the groin level. And this has led the surgeon to explore the possibility of using the retrorectus space for the ventral hernia repair. So which hernias can be dealt with the eTEP repair? So there are many classifications which are there for dealing with the hernias or describing the hernias. But the commonly used classification is a European Hernia Society classification, which was introduced in 2008. And they have described these hernias into two parts. One is a primary abdominal wall hernias and other is the incisional abdominal wall hernias. In a primary, they have divided into midline and lateral, and the size were taken into consideration as a small size to below 2 centimeters, medium size 2 to 4, and larger is more than 4. And the epigastric and umbilical were the midline, and the lateral were the spigelian and the lumbar. For the incisional hernia classification, again they have divided into two parts, a midline and a lateral. And most importantly, they have taken into consideration the recurrent incisional hernia and length and width of the hernia. The width of hernia is most important factor for dealing with the hernia repairs. So W1 is a less than 4 centimeter, 4 to 10 centimeter, and about 10 centimeter they have described. Now for this class, in this classification, what they did is for the midline hernias, they have divided into M1, M2, M3, M4, M5, subxiphoidal, epigastric, umbilical, infraumbilical, and suprapubic. And for the lateral one, they have divided into L1 to L4. L1 is a subcostal, L2 flank, and L3 is the iliac, and L4 is the lumbar. Lateral to the anterior axillary line is taken as a lumbar hernias. Now, all these hernias which are occurring, all these spaces, what they have described in the EHS classification, these can be dealt with eTEP repair, except the fact that the size of the hernia is important. More than 10 centimeter hernias, that I feel is not possible to do with the eTEP repair. So the size of the hernia is important. So how the size is measured is in the periocaudal length and the horizontal length. Horizontal is taken as a width, and if there are multiple defects, then you can take the lateral most hernia defect in the midline for the length, and horizontal direction, the edges of the lateral most hernias are taken as a width. So another classification which is described by the German Hernia Society and International Hernia Society is the rectus diastasis classification. And in this classification, they have again divided the midline into M to M5. And here they describe this diastasis into 3 parts according to the width. And that is the W1 is less than 3 centimeters, and 3 to 5 centimeters, and 5 centimeters. Now, why this is important? This is important because in series of even small umbilical and epigastric hernias, less than 2 centimeter concomitant rectus diastasis was diagnosed in almost 45% of the patients. And it is not going. And Kohler et al. Has reported 31.1% relapse in patients with epigastric and umbilical hernias smaller than 2 centimeters with diastasis recti. So this is again an important point. So one should know the rectus diastasis as well. The preoperative CT scan is very useful, and it allows us to locate the defect, measure it, and establish the strategy for the surgery. And Alfredo Carbonell has given an equation wherein he states that the Reeves-Stopa technique is sufficient when the sum of the bilateral rectus muscle width is at least more than the maximum defect width. And the additional myofascial release, that is a TAR, is necessary if the maximal defect width is closely approximate or exceed the 2x rectus width. So what is important is the dimension of the rectus muscle and the horizontal width of the hernia size. Now here you can see the hernia size is more, and it is also having the lateral hernia. So these patients, they need a transverse abdominal release for sure. Now, while doing the eTEP repair, what one should know is one should know the compartments. The middle compartment is a linea alba. The other compartment is below the rectus abdominis muscle, and these two compartments are joined to do a eTEP RS repair. And if the hernia size is more, then one has to do a lateral compartment dissection or the lateral space dissection to deal with the larger size of the hernia. So these three compartments, they are joined together and to form a platform wherein one should put a mesh. So these three spaces are pre-peritoneal space, retrorectal space, and pre-transversalis space. So out of these, the pre-peritoneal space is utilized for the midline crossover. So for the hernias which are in the umbilicus and below the umbilicus, the midline crossover is done in the epigastrium. And for the hernias, those are above the umbilicus or in the epigastrium, then the hypogastrium space is utilized for the midline crossover. So now you can see the infraumbilical midline hernias that can be dealt with the eTEP repair. And what one should do is one should dissect at the one retrorectal space, then cross over to the other space, and then deal with the complete hernia from above down. Now, for doing the closure, if the size of the defect is, or width of the defect is more than 8 centimeters or so, then many a times for the closure of the posterior rectus sheath and a linea alba, you need a TAR procedure, or it should not be a complete TAR. It might be a unilateral or bilateral, or it's a limited TAR as well. So for the epigastric hernias, what one should do is you can utilize the space, introduce the trocars in the one retrorectal space, and then do a midline crossover in the hypogastrium, and then deal with the hernia from below up. Now here, the size of the hernia in epigastrium is really does matter. If it is more than 4 centimeters, then many a times, as already described, that you might need a transverse abdominis release on either side. So that is for the closure of the defect. Now, for the entire incision from the xiphisternum to infraumbilical region, many a times we can get such type of hernias also. So here also you can try this, but the size of the hernia is important. So small size hernias, you can up to 5 to 6 centimeters, you can deal with this. And here you can utilize one retrorectal space to dissect and then do a crossover in the hypogastrium, and then go to the other side, and from below up you can dissect completely. And for the closure, you can put another trocar in the upper abdomen and do the closure from both the sides, from the head end of the patient and from the leg end of the patient. And if at all the size is more, then if you are not closing properly the posterior rectus sheath, then you have to do transverse abdominis release, limited transverse abdominis release in these cases. So the other hernias, like those hernias are of a horizontal shape and in the midline. For those hernias, you can go into one retrorectal space and then dissect it. And from both the sides, either in the epigastrium or in the hypogastrium, you can do a crossover and deal with these hernias. But here, mind well, these hernias might require a transverse abdominis release, which is a unilateral one. So these are all midline hernias. For the lateral wall hernias, most commonly what we will we get this patient for the post appendicectomy, open appendicectomy hernias. Now these hernias that can be dealt with the eTEP repair. For this, you should utilize the opposite side rectus muscle, rectus space, and then you can enter into a posterior rectus space and dissect it, do a midline crossover in the hypogastrium, and then deal with such hernias. The other method of dealing with such hernias is, and even in these patients also, you need a limited TAR from bottom to up. So you have to release the at least the posterior labella of internal oblique that can be divided. For dealing with such hernias, again, the other method is without crossing the midline also, you can deal with these such hernias, and you can dissect on the ipsilateral side of a rectorectus space and then put a trocar and do a dissection. And again, from bottoms up, you can do a bottoms up TAR for this particular hernias. Now, the hernias which are in the subcostal region, it is a post cholecystectomy hernias or even a post HPV surgery hernias. These hernias are, you can deal with these hernias with the eTEP repair, and these can be dealt with again with the, you can enter into a left side retrorectal space, and then from the hypogastrium, you can do a midline crossover and then deal with such hernias. But while doing this, you always need a bottoms up TAR. From below up, you have to divide the transverse abdominis release. Now, for the hernias which are in the flank region, these hernias can be dealt with without crossing the midline or without doing a midline crossover. So you can enter into the retrorectal space on the ipsilateral side, and then from bottoms up, you can deal with these hernias and doing a limited TAR, and you can achieve the larger area of the dissection, and you can put a larger mesh in these particular cases. Now, there are few cases what we can get regularly is the bone graft after, especially the orthopedic procedures like a bone graft and even the urological procedures. You can get the hernias at these sites, and these hernias can be dealt with without doing a midline crossover. You can do a ipsilateral retrorectal space dissection and then put a trocar like this, and you can deal with these hernias, and you can then put a mesh, a larger mesh in this particular area. But these procedures, they do require the transverse abdominis release. So there are the last type of hernias are the lumbar hernias. So lumbar hernias, there are L4 hernias. For development of the pre-transversal space, as Dr. Ramana has already mentioned, you can directly put a trocars into a pre-peritoneal space, and after crossing the linea seminolaris, you can see here the 3 ports, and they are after that you can dissect the space developed between the transverse abdominis muscle and the peritoneum, and then you can deal with these particular hernias. And this picture has been taken from Hojeta's presentation. And there are other hernias like a double domain hernias. You can get these hernias like umbilical hernia as well as a bilateral inguinal hernia or unilateral inguinal hernia. These hernias can be dealt with eTEP technique. You have to go into one left side retrorectal space and then make a crossover in the epigastrium. And after doing the crossover, you can deal with the umbilical hernia first, and then from up to down towards the symphysis pubis, you can dissect, and you can put another trocar on the other side, and then you can deal with both the inguinal hernias as well. The relative contraindications are post-HPV surgery, that is the falciform is taken down in these particular procedures. Hence, the crossover becomes very difficult. So especially in liver transplant patients, the eTEP procedure are become very challenging, and one should not do this procedure in these particular hernia cases. The large scar extending from the zipisternum to pubis with large incisional hernia with suspected bowel adhesions or Swiss cheese defects, large Swiss cheese defects, these cannot be taken for the eTEP repair for sure. The obstructed hernias is another relative contraindication. Then the previous IPOM repairs, wherein already the mesh is stuck up to the posterior rectus sheath, and it will be very difficult because the mesh is already fixed with the anti-abdominal wall by the transfacial sutures or the tackers. So it becomes very difficult to go for the eTEP repair. So previous sublay repair also, it's a relative contraindication. And the most important is the defect larger than 10 to 12 centimeters. So these hernias, those are very difficult to deal with the eTEP procedure. So one should avoid that. On a CT scan, if you see the picture like this, and there is already the bowel is adherent to the anti-abdominal wall or the hernia sac, then in these cases, eTEP is really contraindicated. For the eTEP, for the inguinal hernia, there are specific indications like a short distance between umbilicus to symphysis pubis, large inguinoscrotal hernias, and incarcerated sliding hernias. Then the obese and post-bariatric patients, and previous pelvic surgery. These are the specific indications for the eTEP for the inguinal hernias. So eTEP repair, it has a place in a laparoscopic ventral hernia repair, And for the defect size between 4 to 8 centimeter, it's the most ideal approach. And for the small midline hernias with a diastasis of recti, you can utilize this procedure. And all principles of Reus-Topa repair are followed in case of a eTEP repair. So restoration of architecture of the abdominal wall and also its functionality and possibility to extend laterally the retromuscular dissection, if it is needed, performing the TAR gives laparoscopic retromuscular repair of ventral hernias the chance to become a gold standard in laparoscopic ventral hernia repair. Thank you very much.
Thank you, Rahul ji, for a very comprehensive, very well illustrated talk. I think next time we will invite you to give us a talk on how to do those illustrations in a free and easy manner.
Yeah.
There is one question, and also Ramana sir wants to put in a comment. I think that first I'll take the question from the audience. The question is, if a previous eTEP has been done for an inguinal, now presenting with a ventral hernia like an umbilical, can it be done by an eTEP approach?
Yeah, that is possible, because the retromuscular space in the ipsilateral or opposite side retrorectus space, that can be is a virgin part, and that can be dealt with eTEP approach for sure.
Shouldn't be a problem, sir. So Ramana sir, your comment?
Yeah, Rahul, that was really a fantastic talk, very impressive. I would like you to share the screen once more to show the slide on contraindications. Can you just throw that up quickly?
Yeah, please. Yeah, 1 minute. I'll share that.
Yeah, that's a very good point. HPV surgery is really difficult. Second point also, I totally agree. Obstructed hernia, agree. Previous IPOM repair would be an indication for surgery, not a contraindication. Previous sublay repair, it would be a relative contraindication. Absolutely agree with that. Defects larger than 10 to 12 centimeters, I would say that 15 centimeters is generally what most of us consider as the highest limit beyond which we would not go. Though if you have a robot, you can probably do closures for defects bigger than that. But 15 centimeters
that is true.
would be the upper limit. But it's always good to be prudent and conservative and say that, okay, let's limit ourselves to 10 to 12 centimeters defects, and quarrels about that. In terms of a personal policy of approaching the operations, but purely in terms of a blanket recommendation, I would say that there are two here which should not be totally appropriate.
Okay.
Thanks again.
Yeah, thank you.
Thank you, Ramana sir. I have a question for you, Rahul sir. You've started with an eTEP, then you've decided this is not going to be just a plain and simple eTEP. You need to do a TAR. So when do you decide just a unilateral TAR is going to be more than enough, or you might have to do a bilateral release?
See, in my practice, what I have realized is while doing the posterior rectus sheath closure, or the posterior peritoneum and the posterior rectus sheath closure. So while doing that, many a times it has happened that it is becoming very, there is a pressure on the posterior rectus sheath, and there is a high chance that one can get disrupted in the immediate post-operative period, causing the complication in the immediate post-operative period. In those situations, what I have realized is many a times I need to release the posterior lamella of internal oblique from below up, because there is no muscle as such in that area. So either on one side you can dissect it, or you can cut it and see whether there is a proper approximation is there, and the laxity is also is good. Then according to that, I choose whether I do a choice regarding unilateral or a bilateral. But for just closure of the posterior rectus sheath, needing of a complete TAR on both the sides, it has not happened in my practice, and it should not be done according to me.
Right, sir. Thank you for that clarity on that point, sir. Thank you again, sir, for this very nice talk. Hope to see you in better times in person.
Yeah.
Right.
Thank you.
Thank you, sir. I'm handing over back to Kanagavel, sir.
Thank you, Dr. Naveen.
Good afternoon. Thank you once again for joining us here. It's my pleasure to introduce our next international faculty for today, Dr. Azad Akhmetov, who will be talking to us on access in eTEP, especially with Dr. Rahul giving us such a wide variety of ports for each type of hernia. The talk on the access and the right choice becomes very important. To just give a quick introduction about Dr. Akhmetov, he's a advanced laparoscopic surgeon practicing at St. Petersburg, Russia, with a special interest in hernia. He's been a member of the IHC and the European Hernia Society, and he's also a very active member in the Russian Society of Surgeons. Over to Dr. Akhmetov, please. You can share your screen, sir.
Good day, dear friends. I hope you can hear us well. And I will talk from Russian team, from the main surgeon, Dr. Azad Akhmetov, and our teacher, and me, Alexandra Mitsinska, and Michael Mitsinsky. So, one moment. And can you see the presentation?
No.
Not yet, please. No.
One moment. Okay.
Does she have sharing rights? I hope she does.
Okay.
Yes.
And now? And now?
Yes. Yes.
Yes. Thank you. Thank you. One moment. Okay. And so now we will try to tell you about the choice of safe access for extraperitoneal technique. And we live and work in Russia in the beautiful city, St. Petersburg, and you can see the presentation of our center. The city is famous for its history, and it was built by Peter the Great. And the revolution of 1917 took place in it, and it has always has been the significant cultural military symbol of the country. And we work in a clinic dealing with general surgery, laparoscopy, herniology, and bariatric surgery. And at the moment, our team with Azad Akhmetov have the most extensive experience in performing eTEP plastic in St. Petersburg. It's about 150 operations, including complex AVR cases. And in addition, we perform about 200 hernia surgeries a year. And our team is actively developing the Aurora Herniological Register. We believe that such projects are very important for the development of herniology all over the world, and especially in Russia. And our disclosure include Karl Storz, Medtronic, and Johnson & Johnson lectures and masterclasses. So in our work, we focus on the balance between correct and safe and convenient access to the retromuscular space. And let's take the example of some types of surgical interventions that are usually common with eTEP access. There are certain rules which include that access must be safe without damage to internal organs and blood vessels. It should provide good visualization for subsequent actions, and in the future should be used by the port in order to minimize the number of ports. So, anatomy of the anterior abdominal wall. As you know from the previous lecture, above the umbilicus in the composition of the back layer of posterior rectus sheath, there is a significant layer of the peritoneum, transversalis fasciae, and transversus muscle, and the rear plate of the internal obliquus muscle. And this layer is the strongest in the umbilicus, and just below it is not so strong because the transversus muscles are shifted laterally and there is no muscle component. And this leads to the first conclusion. The access is safer in the upper part of the anterior abdominal wall. But of course, the number of surgeons also make an entrance at the point below the umbilicus, just above the umbilical ligament, if they have enough experience with the inguinal hernia techniques. But we never forget that in number of patients, especially those who are old and thin, it is possible to damage the posterior rectus sheath in the upper part. So, for example, to perform surgery for ventral hernias, the most convenient access is this for the upper crossover and this for the lower crossover. And for the inguinal hernias, the access varies greatly depending on whether the hernia is bilateral or not and the surgeon's preferences. So, if the posterior rectus sheath is damaged at the beginning of the operation, carbon dioxide will penetrate into the, not into the retromuscular space, but into the abdominal cavity, which will begin to fill and compress the retromuscular space and will not allow us to walk. In this case, we will have to put the small 5 mm trocar in the inflated abdominal cavity to vent the gas, and we also recommended reducing the pressure to 10 mm Gidrargerum or re-enter the retromuscular space from the other side. Or if you have already installed trocars, you can try to help yourself with tools by pressing on the posterior rectus sheath and creating the space for yourself artificially. It is much easier to do this with the robot. We don't have it. And if you have already completed the crossover. In general, you should try to damage the peritoneum as late as possible and not to go to the scar tissue or hernia sac until the very end. The access point should be planned by the CT data if aware is planned. And you need to answer the question if it is generally possible to perform the eTEP plastic in such patients. Maybe it is probably safer to perform laparoscopy immediately to minimize the time. So we don't perform CT in the case of simple primary hernias or inguinal hernias. However, this is a very good method for visualizing muscle and aponeurotic structures. With CT reconstruction, the anatomy is clearly visible. And we are focused on bone structures. So you can see it on the CT reconstruction in the slide. Also, according to the ultrasound data, we can determine the linea similionaris on the both sides and the border of rectus muscles in order to not only safely place the port, but also conveniently for ourselves. This manipulation is convenient to perform before the surgery in the process of TA block. You can see the TA block in the slide. And also before the surgery, Azad examined the patient and draw anatomical landmarks with the marker. He asked the patient to strain the muscles and mark the boundaries of the rectus muscles. So in the video, you can see how Azad performed anesthesia with anesthesiologist and look the anatomy of the muscles. And you can see the ultrasound. And he makes the TA block. Also, one of the most reliable methods of the entering into the retromuscular space is the Visiport, which together with the direct optics allow us to clearly find the necessary layers. You can see Vladislav Burdakov in the slide. So after the dissecting the skin, you can see the subcutaneous fat and go to the fascia and cut it. And then we rest against the transversally striated fibers of the aponeurosis. This striation corresponds to the anterior sheath of the vaginas of the abdominal rectus muscles. And if the drawing is different, we need to make sure that we are in the right space. And then we cut the aponeurosis with the knife. we need at about 2 knife movements, and we see the muscles running parallel to the patient direction. And if fibers is in different angle, you are in the wrong layer. And then we carefully pass through the muscles and don't walk with the knife and start moving the visiport down to the pubis. And then pushing the 12 millimeters pore itself in the end. We are working on 15, 17 millimeters degrees of pressure. Sometimes we also use optical ports, Eticon or Medtronic, but these ports are not very secure for a number of reasons. It is difficult to see the layer at the tip of the port, and it is not good enough visualization. But if we need to go into the abdominal cavity, it's a very great tool. It's a great tool. But also the sharp edge of the port can damage the posterior rectus sheath very quickly. And we saw the video of entering the colon with the help of these ports. So it can cause the tragedy. And also the port can injure the lower epigastric, the inferior epigastric vessels. It's our personal experience. And bleeding at the entrance is very difficult to stop. And if we put port in the middle of the rectus muscles in the eTEP reverse stopper, we will spend time to re-ench it later. With inguinal hernias, we need to put the port exactly in the space, exactly like this. So, since we need to perform an entry into the Bagro space and visualization on the lateral side. And you can see that in this case, Azad will have to set the port again. Our team like manual access. We think that it is very safe if the patient is not too obese. But if the subcutaneous fat is more than 6 or 7 centimeters, it is quite difficult to perform the manual access. However, for the thin patients, this saves money. So you see the skin dissection, then the faster dissection, then the aponeurosis clearing with the finger. So then Azad put the index finger and he clear with the finger the area under the muscles. He does it very carefully in order not to damage the vessels. And then he installs a 10 millimeters port into the resulting space under the rectus muscles. So you can see how he does it, and insert the 10 millimeters port and seal the skin, let the air blow and enter the optical system. And we think that this access is very familiar. And this is another example of the manual access. You can see how we do the skin anesthesia and the skin dissection, and then the faster dilution, and the cleaning of the area under the rectus muscles. With the help of the finger, and then inserting the 10 millimeters port. Dissection of the retromuscular space is also a critical stage of the operation. In the case of inguinal hernia, you can use the balloon. This will give instant space above the bladder, and during its inflaten stop a small capillary bleeding. However, it cannot be installed below the pubis and the bladder, so it can damage the bladder or blood vessels. And we can't inflate directly under the rectus muscles, so the posterior rectus sheath will be break. And the operation will become impossible. But in experienced hands, it is it's a great opinion. Our team with Azat Akhmetov prefer optical dissection with the laparoscope. A 3D camera is not suitable for this technique since it doesn't have a changeable angle of view. For this technique, you need to turn the optical fiber for 3 hours to perform dissection on the left and for 9 hours to perform dissection on the right. And excuse me. And we see how the smooth edge of the video camera will allow us to mobilize aponeurosis and linea semilunaris and the medial part of posterior rectus sheath without damaging the vessels. And it is also possible to walk in the area of space of red cells, and it is simply and safe. So in this video, you can see how Azat is doing the dissection with the laparoscope. The small vessels that leads medially to the umbilicus is better to cross immediately, so it can bleed when suturing the linea alba or installing the trocar into the umbilical area, if we're talking about the inguinal hernia. And it is necessary to walk carefully and without the wide movements and not sharply. And we use the iron method, so the tissue will part itself and gas will help us. Some mistakes is damaging large vessels, inferior epigastric vessels, destroy the posterior rectus sheath and begin to mobilize the hernia sac for inguinal hernia, or start doing the crossover in the area when the ligament is very thin. That is should be done very high, and we need to according to C data, we need to make sure that there is about 7 centimeters from the xiphoid process and from the pubis to the hernia defect for the safe crossover. And some not beautiful moments of the operation, for example, bleeding that started literally at the beginning of the surgery due to the exgasive process. And such episodes make the surgeon nervous, but we continue the operation. And in this video, you can see that the case, the patient after the IPOM plastic, the previous IPOM plastic. And here is the video of the entering for the lower crossover for ventral hernia that performed correctly. So Azat, after the skin dissection, he see the subcutaneous fat and anterior sheath and rectus muscle and posterior rectus sheath. So thank you so much from Russian team for watching and listening. See you all 12 December 2020 for our common conference, Surgery in COVID-19. And thank you so much for the opportunity to take part in your conference. Thank you.
Thank you, madam, for a wonderful talk. I just have one comment slash question. Either one of you can take it. My question is, what was the best possible entry technique you would advise for beginners for eTEPs, especially when there is a lower midline ventral hernia? Would you be rather advise a balloon or a direct entry, or what would you advise, ma'am?
I understand correctly for lower midline ventral
Yes,
hernia. Yes.
Yeah,
Okay.
yeah, yes.
I will ask to Azat as our surgeon and teacher, and he will answer, and I will translate. Okay. Thank you. Азат Данисович, вопрос такой, значит, наиболее для начинающих хирургов, какой наиболее оптимальный заход для нижней срединной грыжи, я просто быстро говорю, вот, который вы бы посоветовали, баллон или там визипорт или мануал и так далее?
Alexandra Igorevna, спасибо. Alexandra, very great speaker. Thank you very much.
No.
Для таких пациентов я бы рекомендовал вход в левое ретромускулярное пространство в левом подреберье при помощи визипорта.
Azad recommended the entering into the left retromuscular space with the help of the visiport for the beginners.
Is there any other questions from any audience, or we can move to the next talk, Dr. Kanagwal?
Dr. Ramana, would you like to give your comments?
No, I think it was a fantastic talk. It's just mind-blowing the quality of talks that you have managed to organize. Thank you very much for this. It's a treat.
Please go ahead, Dr. Alexandra.
And I will say again, thank you so much, especially to Dr. Ramana, for the opportunity to take part in your conference. We are admirers of your practice. Thank you so much. Thank you.
Thank you very much. Thank you.
Thank you, Dr. Azad Takimetov and Dr. Alexandra, for making this evening a possibility and sharing your very, very brilliant videos. Thank you so much. And we move on to the next talk. Can we have can I have Dr. Ashwin to introduce the speaker, please? Dr. Alexandra, can you please unshare your screen?
Yes, one moment, sorry.
Thank you. Thank you.
Вот так вот, да, правильно? Остановить видео. На зелененькую кнопку. Остановить. Ага.
Thank you. Thank you.
Thank you.
Dr. Ashwin.
It gives me great pleasure to invite a young and dynamic surgeon, Dr. Harsh Sheth, practicing at Mumbai. He has a keen interest in minimal access hernia and bariatric surgery. I now invite Dr. Harsh Sheth to deliver his talk on midline closure and defect restoration. Over to you, Dr. Harsh.
Thank you, Dr. Ashwin. I'm just going to share my screen. So I'm going to be speaking on midline closure and defect restoration, but also giving a few video clips of the steps before and after the same. So the access and creation of the left retrorectus space has pretty much been covered. We'll go step by step to describe most of the other steps. As you can see, the port positions for most of the M3 to M5 hernias that we do are pretty standard. We use left retrorectus 12 millimeter with a 5 millimeter in the middle and a 10 millimeter either at the level of the umbilicus or slightly below, along with a 10 millimeter in the right subcostal region. Now, the access to the left retrorectus is usually created with the camera in the left subcostal plane. But once the access is gained and the left retrorectus space is created, what's the next step? That's the midline crossover. Usually the commonest method of crossing over is the cranial method or superior method of crossover. The image is courtesy Dr. Ramana's publication on landmarks of eTEP. Now what we normally do is place the camera port on the left side at the inferior most port using the 12 millimeter and the 5 millimeter as the two working ports in order to allow for crossover. As you can see out here, we're trying to cross over as high as possible. The left hand, we usually give a very gentle traction to the posterior rectus sheath in order to facilitate the dissection of the posterior rectus sheath and separation from the overlying linea alba. The crossover obviously is performed superiorly, but there for surgeries for M1 and M2 hernias, the crossover would be more appropriate when done inferiorly, which I will be demonstrating subsequently. So out here, once the crossover has been performed, from the left, once the left posterior rectus sheath has been incised from the linea alba, the falciform ligament is exposed, and the falciform ligament along with the peritoneum is dropped off to expose the linea alba and the posterior rectus sheath on the contralateral side. Here we can see the linea alba and the posterior rectus sheath on the contralateral side. Often it's difficult to identify the posterior rectus sheath on the contralateral side, and a very simple technique to do that is using the monopolar to check for muscle twitching. I usually prefer to use the ultrasonic to, especially the one with the curved jaws, to dissect the posterior rectus sheath of the linea alba. It makes it quicker and a lot easier. So this is a video from one of my earliest eTEPs, wherein I had to do a crossover in the superior aspect, but unfortunately started the crossover extremely low. As you can see, this is the ideal space for the crossover, but I went extremely low, and as a result of which I encountered the peritoneum immediately without any falciform overlying it, and created a peritoneal buttonhole. It happens when you're not when you don't enter the right space, and if this does happen and the peritoneal buttonhole does occur, we usually create a wider space in the preperitoneal space to access the linea alba and the posterior rectus sheath on the opposite side, and try and avoid the pneumoperitoneum being too much of a problem in this case. Here you can see the posterior rectus sheath in the same case being incised on the contralateral side, wherein the rectus muscle is visible underneath, overlying the posterior rectus sheath. This posterior rectus sheath dissection is then continued cranially in order to encounter the frenulum sign, as Dr. Ramanna et al. Have described in the landmarks of eTEP paper, which is, I think, one of the most important papers to read the eTEP approach. Now, again, how to accurately identify the posterior rectus sheath, as I told you earlier, this is a fantastic demonstration wherein you can see that there's no muscle twitching when you apply the monopolar cautery to the linea alba, but it twitches over the posterior rectus sheath because of the overlying rectus muscle. So this is a very easy way to identify it and avoid any problems with the identification of the posterior rectus sheath on the right side. So for the midline crossover in the inferior region, as you can see, the inferior crossover out here, again, this illustration has been taken from Dr. Ramanna's paper. Here we attempted caudally by placing a 5 millimeter port just at the level of the umbilicus and going to the opposite side. Following this, ports can be placed in the hypogastrium and the iliac fossa on either side to enter the retrorectus plane on the right side. Following this, we can see the volcano sign once we encounter the hernia sac and take down the hernia. Now, the question is, should we go intraperitoneal or stay totally extraperitoneal? Now, that really depends on the size of the hernia and the ease with which you can reduce the hernia contents. As you can see out here, the hernia size is not really big, and we can reduce the hernia contents very easily, and hence the posterior rectus sheath and the peritoneum has not been opened to create a very wide defect. It's a very narrow defect, which can be easily sutured and can be handled very easily. But out here in this case, because there was an irreducible omentum and intra-abdominal adhesions, we actually had to open up the peritoneum and PRS. And here you can see the intra-abdominal adhesions had to be taken down with the omentum having to be reduced from the hernia defect, and that's why opening up the peritoneum was essential for such a case. Now, when we do open up the peritoneum for such cases, it's important to stay close to the hernia defect, not too wide and not too lateral, as that will result in a posterior rectus sheath defect, which is really, really wide. Out here, as you can see, we communicated the posterior rectus sheath in the midline eventually, and then took down the scar plate as well, which was there over the linea alba. Because this patient had a wide divarication, we anyways had to restore it with suturing, and hence we thought it prudent to take down the scar plate, even though it involves injury to the linea alba with the monopolar cautery. So once this is done, we always assess the gap in the posterior rectus sheath as is usual, as most people do. before doing the midline closure. As Dr. Rahul very nicely demonstrated in his talk, any any gap, any hernial defect more than 8 centimeters is usually not easy to close in the midline, and hence preoperative a preoperative workup for the patient and a preoperative CT will help us identify those patients who can easily get an eTEP approach with the right stopa rather than getting a surprise intraoperatively. Here you can see the posterior rectus sheath is very easily converging in the midline, and that's when we go ahead with the posterior rectus sheath suturing. There are two ways in which we use the ports for the suturing. One is the parallel ports for suturing with the camera in the right subcostal and the working ports on the left side, as you can see out here. We usually use a 2-0 absorbable monofilament braided suture as is standard with most people, and close the posterior rectus sheath. Out here, the defect in on the posterior side is closed. Now, this is an interesting case that we did very recently, wherein closure of the posterior rectus sheath defect was not possible because of a deficient posterior rectus sheath peritoneum complex in the infraumbilical region. This was secondary to a partial cystectomy, which was done for a CA bladder by an oncosurgeon in Mumbai. And the patient came with a hernia, with an M3 hernia, and needed a hernia repair. It's important to have a salvage option for such patients. Out here, our salvage option was an IPOM. But what we noticed is there was a neoperitoneum which was formed with the omentum being, kind of forming a very nice layer of neoperitoneum, which allowed us to kind of close this defect and prevent the mesh from being in contact with the intra-abdominal organs. And that's why we went ahead with the closure and actually placed, a proline mesh in the retrorectus space. Here you can see we are just closing this omentum or the neoperitoneum to allow a nice retrorectus space or a preperitoneal space to be created. So closure of the midline when it comes to the anterior hernia defect. Out here, we usually use the camera port in the left subcostal region with the working ports on either side to achieve adequate triangulation, as is in this case. Hitch the hernial sac down along with each stitch in order to prevent any postoperative seroma formation. This closure usually we do with a backhand technique with the needle held on the backhand with the needle holder on the right hand and Maryland forceps on the left hand. But there's another way to do it, which basically prevents the surgeon and the camera person from clashing with each other. And that is closing it with the camera on one side, that's in the right subcostal port, and the working ports on the other side, which is on the left side. Usually this type of suturing is difficult and requires a bit of expertise, but with practice, it does come about very easily. So out here, we've used the forehand technique rather than the backhand technique, as you can see. It's a little more difficult and a little more challenging, but sometimes can be useful, especially in those areas which are difficult to access with the backhand technique. So out here, we're closing the entire divarication, not only the hernia defect, because the patient had a wide divarication of around 4 centimeters and needed closure in order to restore the midline. And the final step obviously would be mesh placement. Out here, for the mesh placement, we normally roll it from either side and bring it to the center and then unroll it when we put it into the retrorectus space. That's about it from me, and I'd be happy to take any questions. Thank you.
Thank you so much, Harsh, for this wonderful talk. Could you just briefly tell us what are the advantages of closing the defect? I think that's more relevant to your talk.
Sure, absolutely. So advantages of closing the defect anterior, we just, as has been described in most of the presentations before me, the main advantages of closing the hernia sac or even repairing a divarication is you're restoring abdominal core strength. You're restoring strength to the linea alba, which is basically the main source of strength in the abdominal core. And the posterior defect obviously prevents the mesh from being in contact with the intra-abdominal organs. What is to note for posterior closure is that it should not be too tight. If at all the posterior closure is too tight or there's extra tension while performing the posterior closure, there are salvage options like doing a limited TAR or even a bilateral or a unilateral TAR, depending on the type of defect and the indications.
There's a question from the audience asking, is it mandatory to close defects less than 3 centimeters?
Yes, I think it's absolutely essential to close all defects, I think, even if they are less than 3 centimeters, for the simple reason that we are restoring strength to the midline for any hernia defect, be it even 3 centimeters or 5 or even 8 centimeters.
I'll just put in one point here. You may be right, Harsh, but as of date, we have no evidence to say that there is any benefit to closing defects less than 3 centimeters.
Yes, I agree, Ramana sir. And my usual practice, our usual practice is to close them. But yes, I do agree that there's no real evidence to support that.
Also, there's another question from the audience asking, what is the ideal pneumo pressure to be kept when you're reconstructing the midline?
Right, so I don't reduce the pneumo pressure because I usually operate at a pneumoperitoneum of 8 to 10 with a flow rate of between 6 and 8 milliliters per minute. So I don't reduce the pneumo pressures excessively while performing the midline closure for these kind of.
Thank you so much, Harsh. No further questions, so we could just move on to the next talk.
All right, thank you.
Thank you, Dr. Harsh. Can I request Dr. Prem to take over, please?
Good evening, everyone. I take great pleasure in introducing our next speaker, Dr. Ankit Mishra. He's a young and dynamic and a very popular member of the AWR surgeons community. He is working out of the Live Life group of hospitals from Hyderabad. Over to you, Dr. Ankit.
Hello, everyone. Thank you for having me here. It's a Sunday evening. I'm going to keep you a little longer away from your families. So when Dr. Kanakbel called me and asked that I have to give a talk on challenges, I had to mull over and think what all is not challenging in modern hernia surgery. And the list was long. But then I thought I must make something which actually is going to help a novice surgeon like myself if they're going to begin their journey of eTEP surgery for ventral hernias. So with this, I'd like to start my presentation. So I have no disclosure or a disclosure that has no relevant meaning to this talk. Everything in modern hernia surgery is challenging. So where do you start? For me, I was lucky enough to have a mentor. I saw this group became into a movement. AWRSC and AWR surgery has been an integral part of my training right from where I started my surgical career. So from training in residency, seeing IPOMs and mostly onlay repairs, I came and started working with Dr. Ramana and I was seeing eTEP. I was completely lost in the very beginning. So I started understanding what exactly this procedure is about. It took me a while to digest all of that. So with him, I understood a lot about AWR and also about life. And the number one lesson was to observe and observe very, very carefully. So first and foremost thing that has gotten me into trouble quite some time as to when he would walk in and ask, have you break the kidney bridge? So when you have a patient of eTEP, it is mandatory that you do this and not forget this. For this, you should have a checklist. This is going to make your life very, very easy because eTEP itself is very, very challenging when it comes to ergonomics. And doing laparoscopy for 6 to 8 hours is not very healthy. So when you break the table, your arms or your ports are in a position when they don't interact much with the rib cage, giving you a leverage to operate on for difficult angles too. These surgeries take a long time. It can even go up to 12 hours. So make sure that you have your SCDs on to prevent any sort of complication related to that. 2 monitors are essential. You don't want to be wasting time in moving one monitor from one direction to the another. And make sure when you work, you have cameras which are above at least of CMOS quality, so they're light sensitive because the space is constrained, and even with a little bleeding, the light gets absorbed and everything becomes dark. So these challenges are actually important for younger surgeons who are operating in not so big setup with a CCD camera, wherein the light sensitivity is very, very low and becomes very, very difficult for them to do important steps of this surgery. Early pneumoperitoneum is good, but it's good for your as a vascular. So you're all jacked up, you're ready to do your case, probably first or 10th, and you start doing the access to the retromuscular space, and there you are. You have made a rent in the peritoneum. Now, you are quite comfortable with these steps, but still, that pneumoperitoneum is going to make that space even more compact. So a lot of the surgeons who are not adopting eTEP surgery is because they feel that eTEP is in a very claustrophobic space. Having pneumoperitoneum is going to make your life even more difficult. And a lot of these surgeons bail out and go transperitoneal and change their plan completely. The solution is no rocket science. Go ahead and do it as an open technique. Use the blunt finger, make the space, get your ports in, and start working. Crossover is the confidence killer. As already been mentioned in this talk before, that you should start your crossover high up for those who start for a hernia in the lower abdomen. Your first port is very, very crucial when you gain access to the retrorectus space. If that port is low, you are definitely going to form the crossover way below. And what that is going to do is that will take you directly into the peritoneum because you will not have the buffer of the falciform pad. There are more crossover issues that has already been discussed, which is injuring the linea alba. So I'm not going to cover that by quickly skipping it. Sac issues. When you see a sac like this, with or without mesh, it's always better to do these cases hybrid. If you don't deal with these cases in a hybrid manner, what you're going to do is you are inviting a very bad name to the procedure in terms of having a seroma. So you're doing an eTEP access repair, your mesh is in the retromuscular space, but your seroma is going to be in the subacute space. Although you take bites of the sac and try and obliterate the cavity of the sac, it's not going to help in a sac of this manner. So don't shy away, just make a small incision, excise the sac, and have a great result to your surgery. You have big ambitions. You want to excel in modern hernia surgery. You have your case, you've well planned, you've read the CT, you know all the steps, you've gone through YouTube videos, but your instruments are short. So bariatric surgery instruments, if you have, are a big plus to your initial journey of venturing into the eTEP space. When you are in that space, it may look as if you'll get away with your usual length instruments, but quite high up while you're there, your instrument, the first hand port, the second hand port, and you're trying to reach to the pelvis, it becomes really very, very difficult with a regular instrument. So having a set of bariatric length instrument is always a big plus. The iatrogenic bulge. You did the surgery. You are in the OR. The surgery is going pretty well. You divide the PRS, you've laid down the mesh, everything looks cool. Now you are probably thinking about whether or not to close the PRS. So your crossover is done. You've got the gain. But the next morning you come for rounds and you see the patient has a bulge. It's a new bulge, which wasn't there in the beginning. So what went wrong? So a lot of the time, a lot of people debate that there is no diastasis. Should we actually close the anterior sheath or not? Should we imbricate it or not? So there is a pure science behind it. When you release the posterior sheath, the linea alba, the tension is lost because posterior sheath is contributing to the tension of linea alba. When you release that, that is going to cause some of the tenting of this linea alba, which was apparently normal, and you thought of not closing it, not imbricating it. So whenever you have made a release, try and repair, try and reconstruct that linea alba, irrespective of it has a diastasis or not. Otherwise, the next day, you're going to see a bulge and you'll have difficult time in explaining the patients as to why they have a bulge after the surgery, which was not even there before. So this is one point which every beginner should understand and close. It's a little more of an exercise, but please do it for to have better results. Now that iatrogenic bulge could be a recurrence, and there is a whole different way of dealing with this recurrence. You need to understand where the recurrence has happened and what's the reason behind it and your next strategy forward. Seromas are real. Although we know that the retromuscular space, the incidence of seroma is less when compared to onlays. But most of the papers don't talk about the position of that seroma. We are concerned about seromas in the retromuscular space because once you have done the surgery, it's a closed space with your mesh in situ. That closed space is bound by the posterior sheath behind, the anterior sheath or your neolinea alba on top, and the mesh in between. The mesh may or may not be fixed, which is entirely the discretion of the operating surgeon. If you have seroma in that cavity, what can happen is it's a closed space. It may not withstand that pressure, and the posterior sheath will be the first one give way. And so that can happen to your neolinea alba too. And if your mesh is not fixed, it may be lying floating. So what do you do of such cases? So this is part of the complication or post-op challenges. Get an IR guy if you don't have that in your team already. You should have this IR guy in your team standby to understand and create that environment of safety. You have to be around them, with them, so that they don't cause inadvertent injury because they don't understand the repair. All they can tell you is that there is a seroma, your mesh is either freely floating or is kind of stuck to the posterior sheath. You need to tackle this seroma in a very, very strategic manner. If you have a rent in the anterior sheath, which you can visualize, through which the serous fluid is tracking to the subcutaneous place, try and place that pigtail through that very seroma, because you're not going to create any further holes or entry sites or defect in your neolinea alba. So it is very, very important that you are around while they are scanning them, and you kind of guide them through to put their pigtail to manage such seromas. Now, all seromas may not need this kind of intervention, but the one that I showed before, the mesh was kind of floating, and that seroma was going to cause problem in terms of posterior sheath dehiscence or even a recurrence. Retromuscular safe is a safe haven for meshes. It's a very, very vascular space, and that's why we like to put our meshes in the retromuscular space. But patients with bleeding diastasis or a leaky capillaries can have these kind of hematomas. And now we know that after quantifying and understanding if it's a true hematoma or an infected one, we can delve back into that cavity endoscopically and give the patient the benefit of laparoscopy. So hematomas can actually happen. You need to be really, really vigilant on these things, especially if your patient was preoperatively on antiplatelets. If you're really concerned about the platelet function, you can do TEG test pre-op. Most of us don't do that. We just stop the antiplatelets 5 to 7 days ago, but have a very, very high index of suspicion. And if you find anything odd, and if you're not a proponent of putting a drain in the retromuscular space, do not hesitate to do CBC, HB level, and a scan to look if there is any hematoma or not. deep SSIs, and mesh infection. Although this space is resistant to infection and the meshes, the implants that we are putting have the capacity to fight infection, these things are real and they are not untouched in the eTEP world. So your seroma or hematoma can get infected and that will give you a deep SSI. But to have the diagnosis of mesh infection, what's important here is you need to have an aspirate which is positive in culture. So that aspirate goes to microbiology. The microbiology tells you if there is infection or not, or which bacteria. Now, the beauty here is you may not need to take that mesh out. So explantation may not be needed. You can very well salvage the mesh. And that's exactly what the beauty is of having to place that mesh in the retromuscular space. So broad spectrum antibiotic is going to help. Most of these patients who have mesh infections don't have florid sepsis. If they have, then what remains is a local exploration with explantation of the mesh, because then it really becomes difficult to treat these infections. Mind you, time and again, we have said that these meshes have to be macroporous, because those are the kind of meshes that are kind of resistant to having biofilm formed around them, and the penetration of immune cells is really very, very better into the structures. PRS disruption. You're closing the posterior rectus sheath and you thought that it looked all right, but on day 2, day 3, day 4, the patient comes with abdominal pain. You can't really make out because the abdomen looks more or less all right, or there's slight distension, which could be attributed to their fatty status. But you need to have a very high index of suspicion of PRS disruption. Do the scan, rule out this. When you do a scan, what you'll see is your hanging posterior rectus sheath with bowel in between the anterior rectus sheath and the posterior rectus sheath. You cannot wait. This is an emergency wherein you need to go laparoscopically and reduce that bowel. How can you cannot have this problem? There are a few simple things that I'll talk to you about later. This was one of our case that we did in Kolkata. So the patient presented 3 days after with abdominal pain and episodes of vomiting, which was non-bilious. We did a scan, we found that the PRS had given way, which looked absolutely fantastic while closing. Luckily, this patient, the bowel was healthy. Now that posterior sheath is not going to come together. There's element of inflammation there and the sheaths have retracted. So don't try and get those sheaths back together. They will never come. Even if it does, it will give way again. So your bailout plan in this kind of situation is doing an IPOM and bridging that posterior sheath. We did not take out the mesh which was placed in the previous operation because it was very well integrated to the top. It wasn't free floating and we did not see anything ominous during the surgery. So PRS disruption needs your high index of suspicion. Now you may ask, how do we avoid this? When you have a patient, you have done the scan, start using Carbonell's equation. This is going to be really, really helpful. You know when and which patients will need TAR. And if they need a TAR, do not shy away from doing a TAR. While you are creating your retrorectus spaces and crossing over, preserve as much PRS as you can. So gauge well, cut well. By the end of your retrorectus dissection, you should have a floppy PRS. If your PRS is still hanging, then there is some problem. If it's on the floor and floppy, it will come back. A lot of the time, most people have this notion that PRS gives the strength to your repair, but it does not. PRS has its own strength, but that does not give strength to the overall closure. We are actually relying on your neolinea alba, mesh, and inflammation for strength, not on PRS. So that's only a barrier so that your bowel does not get in touch with your implant. So do not take bites to your PRS. If you feel that there will be tension, try and incorporate a little bit of peritoneum that comes with that PRS. Take parallel bites. Do not pull your V-lock in the opposite direction. Be very, very gentle. bites parallel to the sheath and pull along, never in the opposite direction of it. If you follow these equations, you will not usually land up with PRS disruption unless your patient bucks right after the anesthesia or there was something oddly wrong with the procedure. Now, to overcome these common challenges that we come across in the early part of the eTEP surgery, I think it's really very important to have a mentor by your side. The world is not allowing us that anymore, but I'm sure the time will come back when we can have a mentor by our side. So the platforms like AWRSC and IHC are doing phenomenal work of providing you guidance while you are at your home and at your ease. So do make use of that, participate and gain as much as you can. Always have an extra pair of eyes with you. So call one of your colleagues who has more experience than what you have to mitigate such basic problems. Always have a checklist, starting from your position to having meshes to suture. Always stick them. I have made plenty of mistakes while I was trained. So it is really very, very important that you have a checklist to avoid such small things that can become big later. You need a proper OR setup. Do not compromise on that. Otherwise, you're going to hurt yourself and your patients. Vigilance is important. A lot of the people shy away from doing scan on post-operative day 1 or 2. Do not do that. Have a very strong suspicions about these complications. Critiques. Share your videos. Whenever you do a surgery, record them, share them. Ask your seniors to critique. That will give you a lot of insight as to the mistakes that you are doing, which are completely avoidable. So that brings to an end of this talk. Thank you very much for having me here and spending your time on this Sunday evening with me.
Thank you, Dr. Ankit. That was a fantastic talk. You have really, like you said, going into the eTEP surgeries is not a joke. It's quite a difficult operation. And to go and try to do those operations without proper training and proper guiding, without a proper mentor, etc., can make my life even worse. And you've also given us a lot of tips about, troubleshooting, and because, mistakes happen, and when these mistakes happen, how to overcome them have been very lucidly covered by you.
Thank you.
No doubts from my side. If anybody else has got any comments or doubts, please go ahead. I'll hand over to Dr. Kanagavelu, please.
Thank you, Dr. Prem. I would like to ask a couple of quick questions to Ankit before I hand over to Dr. Deepak and Dr. Ramana. Dr. Ankit, you've been honest in talking and you've been very clear in telling where things can go wrong and do it. You did talk about the placement of the drains. And can you little enlighten us what type of drains you use, how long you retain, and what is the real indication for a drain?
Okay, so in our practice, Dr. Ramana will concur that we did not put any drains, be it endoscopic surgeries or open AWRs. So we were not into drains. If at all we had a patient, like this one time, we had a patient who was on some medications. This particularly patient was a very, very leaky patient. For that, we had a drain. Otherwise, we never put drains.
And the other thing, how often you, at least, I don't have a big experience, but then how often you lose the planes after doing so many cases now over the past few years with Ramana sir as well. And what are the important tips to regain? Because I did listen to both the speakers who said, but talking about the complications, I feel I won't tell it's a complication. It's a challenge to lose the plane and challenge to regain the plane. Let me categorize into two ways. You lose plane on the upper end and you lose plane on the lower end. What is the way out?
Okay, so whenever you lose a plane, the first thing is sit back and talk to yourself what exactly that is you want to do. Okay, where exactly you are in the side of the surgery. You are probably close to your hernial sac and you are losing your planes. You are probably close to a scar. you're probably close to a place where there is a lot of inflammation, and that's exactly why you're losing plane. Step back, think for a moment, go to a virgin area and think what all needs to be on the floor, what all needs to be on the roof. That's the easiest thing that you can do. When you have a lateral defect, let's say, the best thing to not to lose a plane would be, as I said, start from a virgin plane, which everyone does, but tack from both the sides. Start your dissection from the top, come to the defect, start your dissection from the below towards the defect. Now you have a defect. Now try and go around the defect. When you do that, you know for sure that from below you are coming in a plane that you may not be aware of what you're going to encounter, but you have created some space for you to notice that your anatomical landmarks are in place. When you do that from the top, the same thing happens. So you have the posterior rectus sheath, you have the rectus abdominis, you're seeing the lamppost sign. Now, when you come towards the defect, or you come towards a plane of, I say, inflammation or some adhesion, if you follow these principles, it really helps you out.
Thank you, Dr. Deepak. You like to add something before I'll request Ramana sir to give the closing comments.
Yes, sir. I was just going to request Ramana sir to give the final note. You can do the introduction, sir, for that.
Ramana sir, before giving a closing comment, I have a question to you. Is it, I would say, very rare for someone who does the eTEP to have a conversion to an open operation? And where do you think we have to stop minimal invasive approach and we have to convert into open? And then when you open, you don't have many things anatomically lying after halfway through or after mobilizing the planes. What are the challenges we face when we convert?
The issue of conversion in ventral hernia surgery, in eTEP surgery, to my mind, should not exist. Now, that might surprise many of you and say, why not? Any minimally invasive procedure you can convert. Yes, you can. But you should not convert because you got lost and you can't figure out what to do and you're unable to cope with the oozing and the planes and the limited space. Now, why I'm saying this is because today you have a CT. You can assess the patient preoperatively and decide within your skill sets, within your infrastructural limitations, whether you can do this eTEP or, for that matter, any minimally invasive approach, whether you can do it or not. You must have this much self-realization and maturity. If you don't, then you'll have to just blunder your way through on a case-to-case basis and figure out whenever you're screwing up, then you convert. But otherwise, if the defect is such that it will need significant level of skill as well as infrastructural support, you need that level of camera system. So if you need to explant a mesh, if you need to do a lot of adhesiolysis, or if the patient has had multiple surgeries and you're not really going to find a very inviting plane for you. In those situations, if you lack in any way or not, that is going to be a defining point in the outcome. So I would say in that case, like Rahul said, laparotomy with cancer surgery before multi-organ resection, omentum has been resected. Very common when you have radical hysterectomy and all this ovarian cancer stuff. You have a wall of bowel stuck full length on the linea alba on the surface. So to do that eTEP is going to be extremely difficult and probably not worth it. So in such cases, you should not convert. You should straight away go for open rather than try anything fancy. So per se, I would discount conversion as a big issue. I would say prevent conversion by doing open surgery at the get-go. There's no shame in it. All right. But if you have any specific issue like an injury or something, you can always do a small conversion. You can excise the sac or do specific lysis of adhesions or close a bowel injury if you had it, close the linea alba from above, from outside. All of this, a hybrid conversion can help, and really should not be an issue. And worst comes to worst, if you're totally lost, you do a full-fledged open AWR. So does that answer your question?
Yes. And the other thing I would like to know from you is, when we're going through the literature, technically, there have been very clear quotes telling you don't need to do interloop adhesiolysis, because at least I'm sure I've struggled even in open operation, sometimes spending 5 hours, 6 hours, fearing an enterotomy. I go very slow, but then end to end from the DJ to ileocecal junction comes off in hand and you are done. But people may call back to me telling you're wasting your time. Another 72 hours, everything is going to get stuck to each other. But then we always have been taught to do a complete adhesion lysis before doing a hernia repair. How does it fit in eTEP? And are we sort of leaving something untouched? Or potentially, are we leaving a source of future trouble? What's your experience on this, rather? That makes life easier.
There's somebody who needs to be treated, probably. As far as adhesions are concerned, it is standard teaching, regardless of your approach, to lyse adhesions to the undersurface of the abdominal wall to the limits of your domain. So if I'm doing a Reeves topa, for example, whether it is open or laparoscopic or eTEP or whatever, you can lyse adhesions to the undersurface of the abdominal wall as far as the linea semilunaris. You don't really need to go all the way to the flanks, even though they may have plenty of adhesions there. Whereas if you're doing a TAR, then the adhesiolysis has to be pretty much exhaustive as far as the abdominal wall is concerned, because you're going to be doing dissection all the way to the sides. But interloop adhesions, you're not going to lose out if you don't release those. On the other hand, you're saving yourself additional risk of inadvertent enterotomy. And if your enterotomy is undetected in the eTEP space, it could well be undetected. Even recently, we have seen a case of an inadvertent enterotomy, which happened in a robotic eTEP by one of our friends. They were very, very skilled and detected it on table and closed it. But this can happen, and it's very difficult to detect in some cases. So you don't want to risk it unnecessarily. Do whatever is essential, and nothing more than that.
Thank you, sir. Your closing comments, please.
All right. So honestly, it has been pretty much an extraordinary 2 hours plus on a Sunday evening, and every speaker has smashed it completely. I would say 9 on 10 average would be the score. I'm extremely impressed with everybody. I have just a couple of things to say in general, as well as with some specific inputs on whatever has been already discussed today. Does your eTEP operation look good at the end of it? At the end of it, that is, I mean, for all that you have plodded through any number of hours, depending on your experience and learning curve, at the end of it, are you happy? That is a very important question for you to answer. So that linea alba closure should be as good as it can be. The peritoneal closure should be as good as it can be without too many gaps in between sutures or too rough bites, possibly taking bowel underneath it, or leaving a little bit of tension on the posterior sheath. All this has been discussed, but kind of underlining this point that when you're closing off, make sure that the linea alba is closed well, and the patient won't wake up and feel a pop and everything gives way. That should not happen. Second is no question of leaving tension on the posterior suture line. And 3 is, does your mesh look good? Don't have excessive mesh which folds on itself, because that mesh on mesh will not integrate, and that folding will probably increase once the patient starts moving before the mesh really gets integrated into the tissue. So make that operation look good. This is one point I would say. The other thing which we have partly covered is to avoid a complication. When we are talking about lost planes, Ankit was talking about lost planes. And sometimes the surgeon discovers that he has gone into the wrong plane when he sees the balloon of a Foley catheter or when he sees bowel mucosa. Till that time, he was completely naive to it, right? So if you have to step back and assess, do it before that situation happens. So a little bit of caution and conscious aware thinking, like you are walking along a minefield, you never know when you're going to step on a mine. It is initially, at least, it's a good practice to have. And I always say this, that name every structure before dividing it. Just like in gallbladder surgery, you know this is the cystic duct, this is the cystic artery, this is the CBD. Only then you go ahead with committing the act of clipping and dividing. So in the same way, every structure that you divide, even though it's just an areolar tissue or a small vein, you should know which plane it belongs to and what it is. So is this fascia transversalis? Is this posterior rectus sheath? Is this a vessel? Is this a nerve? All of this should be very clear to the surgeon every step from start to finish. That's the way you're going to do this operation smoothly. Now, Richard has pointed out that the PRS closure does not have to be linear. It does not have to be longitudinal. Absolutely. So sometimes you mobilize the pelvic peritoneum well. So in a female, you divide the round ligaments bilaterally. In a male, just do a better myopectineal dissection, dissect more proximally in either Bogros spaces, and then you have the bilateral arcuate lines visible. Now do a small release on either side. You could do it on one or the other, but if you do a small release, like you would do for an eTEP inguinal, for example, then you can do a lot more cephalad Bogros dissection. Now, not many people know that the Bogros space extends from the pelvis to the diaphragm. That entire space is actually the space of Bogros. So you can dissect more proximally, and what happens is the peritoneum gets mobilized and the closure becomes effortless at that time. And the closure doesn't have to be in one straight line from north to south. It can be a zigzag as well, no problems at all. But close it well and close it without tension. So the PRS closure, I would say, is a very, very important part of the operation. Once you have done that, then this entire operation is kind of, it's done as far as that is concerned. So anterior closure has been dealt with very well. Harsh has talked about it. Ankit has talked about it. There is a tendency to take a shortcut and not close it. I would say close everything. Close everything, even though there is no evidence for closing, having benefits from closing defects less than 3 centimeters. Still, it's a good practice. It'll improve your skills and it prevents that bulging. That's very, very important point, that once you close that linea alba, it kind of prevents that bulging from happening, the midline bulging. That is about all that I have to add. Thank you very much for having me.
Dr. Ramana sir, for sharing your wisdom. I thank all the speakers for the evening. Dr. Pramod, Dr. Ramesh Munjani sir for joining us at the inauguration. Starting from Dr. Rahul, Dr. Richard Liu, Dr. Alexandra and Dr. Akhmetov, then moving on to Harsh and Ankit. And then I thank my co-moderators, Dr. Deepak, Dr. Prem, Dr. Naveen, Dr. Kannan, and Dr. Ashwin for making a flawless program. And friends, this is available on the AWRSC Facebook page. There have been few inquiries that we missed the early part. This is permanently available on the Facebook page. So we look forward to have yet another academic program very soon. Thank you one and all. Thank you, Ramana sir. Thank you, team AWRSC, for making this evening possible. Goodbye, everyone. And thank you, delegates who have been with us all through. And thank you, delegates who have been with Facebook all through. Bye-bye. Bye, Professor Richard Luke. Bye, Dr. Asad Akimatov. Thank you. Bye-bye. Bye-bye, Dr. Ragul.
Thank you.